Hello guys, hello family, hello friends. This is Dr. T and welcome to Clinical Medicine with Dr. T. Welcome to part 2 of my 2 weeks experience as a ComServe medical officer. So I did part 1 and I hope guys you like that and it's insightful for you, and I hope you're gonna press that like button and subscribe for those who haven't subscribed to my channel. More content is coming. I think my channel is, I started the channel on the 17th of April, I think about 9 months now if I'm not mistaken, and I have got about close to 220 videos already, so content is gonna keep coming. Yeah, so part 2 of my experience as a ComServe, my 2 weeks experience as a ComServe. So like I said on part 1 that for ComServes, the supervision is very minimal. The supervision is very minimal, and people, they tell themselves that you have done internship and you can't be, no one's gonna babysit you anymore. You need to actually man up, step up and be a doctor. So that's what is happening. And it's not only here where I'm working. I've been talking to other ComServes around, and it's just like that. They're just left to actually make their own decisions and be doctors. So the supervision, I'm not saying there's no supervision, but it's very minimal. It's very, very minimal. And I want to advise you guys that for those who are still in med school, make sure that you read. Make sure that you read, because, I mean, make sure that you read. And I've always said this, that don't specialize before you specialize. When I say that, I've explained this on my my other videos, that people who specialize before they specialize are people who like a certain department, and when they are in that department, they actually make sure that they do the work. They are reading, they answer questions, like, yeah, they are performing. But when it comes to other departments, they are very sluggish and they're very floppy and all of that, because they don't like the department. Not that they don't have the intellectual whatever. They do have the intellectual ability. They do have, I mean, you can't be a medical student if you don't have that Landuka. So people, they choose where they're gonna put focus, they choose what they like, and when you do that, yourself at a disadvantage, because you won't be a GP. You can't really call yourself a GP if there are things that you know nothing about. You should be comfortable with psych, peds, ONG, internal medicine, because those are the things that you're gonna, I mean, everything. Those are the things that you're gonna meet as a GP when you do your ComServe. And so when you, and also during internship, if you put when it comes to when you are doing a certain rotation that you like, all the others you don't care about them, you don't do your course properly, you don't show interest, you don't learn in those, they are gonna catch up with you, because you're gonna be a ComServe and they will call you for a PV bleeding patient. What are you gonna do? Are you gonna, I mean, they will call you for a baby who's got diarrhea and vomiting, and you have to put an IV line. They will call you for a patient who has just collapsed, or they will call you for a patient who has lost a limb. They will call you for a patient who's got fractures. They will call you for everything. They will call you in theater for anesthesia. You will be the surgeon doing the operations, C-sections, all those things. So now, if you don't put focus when you do your ONG, you're going to have issues when you do your ComServe. You will have problems when you do your ComServe. And the thing is, one of the reasons why supervision is very minimal is because there's understaffing. Like, doctors are very few. And now you won't have, first of all, they won't be really patient with you, because they have their own workload that they've got to deal with before 4:30. And now, if there's, like, in my hospital, there's like 4 doctors. Now, if those 4 doctors, and we are 4 ComServes, let me say 3 ComServes. So if we kept calling these guys, the 3 of us, we just keep calling them, we cannot make decisions, we are sluggish, we are reluctant to make like decisions, and we always want to be with them when we see patients. They will never finish, and basically it means we haven't been prepared to be a doctor. Because if you're gonna have those kind of problems during your ComServe, then it means you haven't been prepared. So guys, I want to urge you, med school, read. That's the only time you're gonna actually sit down and study, because in internship you don't really study. You sort of like read. There's a difference between reading and studying. So there isn't a lot of studying in internship. There isn't a lot of studying because you're tired and you've been studying for the past 6 years. You don't but it's important to keep your books. Read, at least go through the protocols, see patients, and that kind of a thing. So there's understaffing, doctors are tired, there's like shortage of everything, everyone is frustrated, so there won't be time to actually sit and babysit. There won't be a time for someone to actually sit with you and sort of like babysit you. You need to step up and all of that. So during I want to advise you guys, during internship, those who are doing internship now, I've got one thing that I always did when I was an intern. It doesn't matter what rotation I'm in, I always put in the effort. I always put in the and most people, there are people who think that I'm gonna go back and do surgery. There are people who think that I'm gonna go and do anesthesia. There have actually been people that have been telling me that actually anesthesia will look good on you, blah 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 blah. You know, those kind of compliments. Internal medicine, family medicine. It's simply because when I'm in a department, I work as if I want to be there. Not really that I want to be there. I don't like surgery. I don't like orthopedics. But when I'm in a rotation, I just make sure, because my thing is I want to learn. I want to know. I get frustrated when I don't know. I get frustrated when I don't know what to do with the patient. I don't sit and be comfortable when I don't know what to do with the patient. And if there's something that I don't know, I'm always bothered, and especially when I keep seeing the same thing and I don't know anything about, I become bothered. So don't be comfortable, guys, with not knowing, because once you're comfortable with not knowing, it's just gonna be like that. You will never know. You'll just sit and not know what to do. So try and know all the emergencies in all departments. Try and find, like, have the basics of a surgeon, have the basics of an ONG, we will never know everything, but we should have the basics of PEDS, the basics of internal medicine, the basics of that, then we should be fine. And another thing, during internship, that's one thing this is another tip that I'm giving you. The tips that I'm giving you guys are things that I did when I was an intern. I was that intern that I enjoyed seeing patients that interns were running away from because they're difficult. I enjoyed doing procedures that interns were running away from because they think it's difficult, or whatever the case may be. My thing is this: when you see a difficult patient, you do a difficult procedure, you are an intern, there are seniors around you. When something happens, they are around, you will quickly call them. But it's different when you are a ComServe or when you are a medical officer. You might be the only person there. So if you're not used to seeing, like, I remember some people used to refer step abdomen straight away. You know, sometimes a true step abdomen is when you've got penetration of the peritoneum. As long as you don't have that, that's not a true step abdomen. It might be a step, but it's not a true. It's not penetrating. So when are you gonna be able? If you're gonna, as long as they say step abdomen, you just push these patients away. When are you gonna learn how to actually manage those patients? When are you gonna learn how to research those patients and refer them in a stable condition if you have to refer them? When are you gonna learn how to put up an ICD if you're not gonna see a step chest? When are you gonna, so those kind of things. So yeah, guys, so tip number 3, when it comes to presenting, as you rotate, through different departments, you will be given topics to present. Make sure that you take the most difficult topics. I mean, why would you take something that you know? Why would you take a topic that you know? Simply because you don't want to spend a lot of time on the presentation, because you know, like for instance, if there's HEE, you know, I know HEE, let me just take HEE so that I will spend the least time on this preparing this presentation, so I don't have to spend a lot of time. What about the other topics that you know nothing about? Because you know HEE, why are you going to present HEE again? Because you know HEE. So I'm just making an example. I will tell you something that happened to me when I was doing internal medicine. In internal medicine, we were not given a choice to pick topics, but we were allocated topics. So when I look at my topic, I had heart block. It's like heart block. Wow. Okay. I was happy because it's a challenging topic. It's something that we have never really been taught like in detail, and I've never seen a patient with a heart block. So I was given that topic. That was sometime around November on my when I was doing my first year of internship. Bam, when I was doing FemMed the following year, around May, June, I was in OPD. I was seeing there was this patient, this old lady, I think she was 83. No, not 83, she was like 60 something. I think 67. She came in with dizziness, dizziness spells, fainting spells, and feeling weak, and she had bradycardia. So the first thing I did after examining her, I ran for an ECG. Bam, I diagnosed my first heart block. As we are talking now, that patient has got a pacemaker. So I won't lie to you, had I not presented that topic, I was never going to be able to pick up that heart block. So this is how it helps. So pick the difficult topics that everyone is running away from. Because, I mean, it's not an exam. No one's going to, like, slash you for it. There's no one who's going to, I mean, it's just a learning opportunity. So, and also, personally, my channel has helped me to sort of, like, read a lot. So my channel has challenged me. It has pushed me to actually sit down and go back to my books and try and remember stuff and that kind of a thing. So yeah, guys, those are the tips that I want to give you. Tell you about my call. Okay, let me say, one of the things that I've realized that the rural hospitals, they don't have stuff. They don't have things to, like, equipment. Like, this hospital is one of the most ill-equipped hospitals around. And, I mean, we struggle for almost everything here. Like now, today, as I'm on call, guys, you know, I thought I was going to make a video about this. So as I was, after 8 o'clock, my shift today started at 8 in the morning until it's going to be until 8 in the afternoon. So as I was walking to the hospital, I was like, I'm that one person that when it comes to maternity, I always go to maternity to tell the sisters that, okay, sister, I'm the one who's on call today. So if you've got problems, call me. And then after that, I would ask them, do you have issues now? Because I know people do it differently. In maternity, you rather anticipate and look for problems than to sit and wait for problems. So when I got there, as I was passing the window, I heard them mention my name. So when I entered, I was asking, guys, I heard someone mention my name. What's happening? They were like, oh, they were about to call me. So they told me about this prima gravida 24-year-old that has been 6 centimeters since yesterday. No, not 6 centimeters. That has been 4 centimeters. Or in fact, to them, they said it was 2 centimeters since yesterday. So, and that there was a caput and all of that. So I was like, okay, let me see the patient. So when I examined the patient, she was term, she was in labor, ruptured membranes yesterday, and was draining MSL grade 2, and there was molding. So meaning the patient was obstructed. So the heart rate was still fine. So I said, okay, let's prepare the patient. Let's take the patient to theater. We got to theater, and I called So as they were preparing the patient, I called the second person on call, which is a senior doctor, who's my second on call today. So I called him. I said, okay, doc, I've got this patient, and I'm taking this patient to theater. Please join me for this operation. And then he was like, okay, I'm coming. So what I did, because I want to learn, so what I did, I put the patient on the table. I did the spinal. I did the spinal. And then after doing that, as I was doing the spinal, I was like, can someone call Dr. So and so? And then to say now I'm in theater and I'm actually putting the spinal. So I put the spinal. After putting the spinal, I made sure that everything is fine. Give the patient the vitals were normal. Everything was attached. The BP cuff, the pulse, the ECG, everything was just attached. Patient was doing well. And then I went as I went to go and scrub for the Caesar, the senior just came in. And I was like, okay, doc, I'm going to do the Caesar as well. So your job is just going to be to monitor the anesthesia. So I went, I scrubbed, and then I did the operation. So it's because I want to learn. It's because I want to learn. I want to be comfortable, and I want to be able to do a C-section with another ComServe without problems. So that's why I'm pushing myself. It's only been my this is week 2 for us. Tomorrow is gonna be week 3, and I've done more than 12 spinals, and all of them have been successful. And that was my second C-section in this hospital that I did today, and I did an evac after that. So it's because I want to learn. I want to push myself and be comfortable. So guys, my first day when I was on call, very funny call. You know, the first patient that I saw was a boy who had a pig bite. I don't know if you're gonna call it a pig bite or pig's bite, but yeah, pig bite. I've never heard of it. I don't know if it was ever discussed in class. Maybe I was sleeping or I didn't attend. I don't know, but yeah. And in my mind, I was like, okay, how do I approach this? He was not bleeding. He was fine. The pulses, it was just around the wrist. The radial pulse was there. He had a good capillary feel. The wound was fairly clean. But now, my thinking was like, I was trying to decide, should I close this, suture it, clean it and suture it, and discharge on antibiotics, or can I leave it open, wash it, and let the patient go for dressings so that we can actually do a secondary suture? I don't know, because we know with human bites you don't suture, dog bites you don't suture. I was like, I'm gonna treat this as a human bite. I won't suture it. I'll just clean it, put on antibiotics, and let the boy come in 5 days for a suturing. Those are things that I don't think it's in the textbook. I mean, how often do people get a pig bite? Not often. So I don't think it's something that is in literature. It's written about. So what else do I want to share about my call? So yeah, guys, that has been my experience. And I mean, when you work in a district hospital, you have to understand that when you go to OPD and you're on call, you will see all kinds of patients, and you'll see all age groups. I had the other day a dehydrated 4 weeks old baby that I had to put an IV on, so an IV line on. So you will see everything, and yeah. One other thing, my advice is, one, guys, read. And remember, we are a district hospital, and the people that work here, they will advise you based on experience and stuff. Sometimes there's gonna be patients that you wanna discuss with them, but they're a specialist, sort of like you need a specialist advice. So while I'm still at that, so let me just finish it. So there is no problem when you discuss a patient with a senior. And if you think that the advice that you are getting, you don't really agree with, there's nothing wrong moving on to the second. And that's why I said, try and have friends in all departments in the teaching hospital. So when you've got an issue, you can just quickly ask them, like, hey, I've got this patient, what can I do? So try and do that. One other thing that I want to say is that, guys, you need to polish your presentation. You need to polish your presentation so that when you don't know how to present and you don't know the important information, when you are trying to refer a patient, you'll just get people rejecting your patients. All of them, they'll just reject your patients because you cannot really fight for a patient in terms of giving them what they need to hear so that they can decide whether they're going to take your patient or not. You need to learn how to present, and what to present, and because that's the only time. Because I mean, there's no specialist clinic or wherever, or a doctor on call in another hospital that wants to accept patients. They don't. It's even worse when it's not their patient. So your job is to convince them that actually this patient is yours. I have done A, B, C, and D. Because remember, teaching hospitals, they get referrals from all over the place. So one patient is one too many for them. One patient is one too many for them. So you are the one who have got to actually stand for your patient, be like, doc, not fighting, and be like, doc, I've done A, B, C, and D, and I think this patient has got this diagnosis, and that's why I'm calling you. And then if they are unhappy about whatever, okay, do A, B, and C again. You go and do whatever they say you must do, and then come back and say, okay, doc, I've done A, B, C, and D, and this is how the patient is now. And most of the times when you are spot on and all of that, they won't give you issues. They'll take the patient because they can just see that this is our baby, this is our patient. So guys, that's my 2 weeks experience as a ComServe. I hope you like that. Thank you. Keep subscribing, liking, and commenting. Thank you.